femur is a long bone. Right. You're not going to fit the entire femur on a 14 by 17. It's not like the tibia. It's not happening. Even if you put a diagonal, it is not going to happen. So, what are we going to do? With the femur, we do need to do 2 pictures. So that is why we have 4 pictures for the femur. We will have AP distal, AP proximal, lateral distal, lateral proximal, right? 4 images for the femur. So who would like to be our first patient? In that case, Emily, just have a seat over here, please. And then you're going to lay on your back, head over here by the pillow, face up, please. Okay. So, femur, we do not need to take off the patient's shoes for this one. Where is the cassette currently located? That's right, inside the bucky. Just remember, because we are knee and above, right? Because we're above the knee, this is thick anatomy, so we are going to do this in the bucky. First things first, once you get the patient on the table, what do you do?
Raise it.
Good. Do not forget to raise up your table. Great, patient's up. Now what do we do?
Lock. You could lock it?
Do not lock the table.
Oh, lock the table. Okay.
Because we are working the bucky.
Oh.
If you work the bucky,
Right.
you need to float the table for your positioning.
Mm-hmm.
But before you float your table to position, what do you need to do first?
Center that with the bucky.
Oh,
That's
at
right.
40.
You just center this tube onto your bucky. So let's fix up our tube. We are on the bucky, so I'm going to select the table bucky setting on the tube. We need to make sure to turn on our detent so that things will lock into place. And then I'm going to use lateral. Okay, green light, locked into place there. I'm going to use my vertical. Oops, too low. Okay, about 40 inches, locked into place. Green light, am I done?
No.
No, what am I missing? Right, I still need to bring the tube over the patient. So what do I line this tube up with?
The bucky.
That's right, the bucky underneath the table. So, laser on, and we're just going to line this up with this right here. These 2 are lined up now, correct?
Mm-hmm.
So now, are we ready to work?
Yes.
Okay, good. So tube and bucky, tube and IR are lined up. So, first things first, want to make sure that our leg of interest is coming straight down the table, and ideally we want it kind of in the center of the table. Otherwise, we might run out of room to float the table when we're working. So Emily, I'm just going to have you kind of scoot over just a tiny bit here now. Not too much, just a tiny bit. Very good. So now, even though she's more to the side, the leg we're interested in is closer to the center of the table. So, how do you position and how do you center an AP distal femur? You do it almost exactly like the knee. You're going to turn the leg into an AP position. How do you know when your leg is AP? Because your foot is just going to be very slightly internally rotated, only about 3 to 5 degrees. That means if you check the condyles will be flat. They will be parallel to your IR. Where do you center? You center smack dab in the middle of the leg this way, right? Right in the middle of the leg. And you put the bottom of your light about 1 to 2 inches distal to the knee joint. Where is the knee joint located? How did you find your centering for the
Oh,
knee?
1 inch below.
Half inch.
Half inch
Yeah.
below
The
the
Apex.
apex of the patella. Great. So you know where the knee joint is. Half an inch below the apex of the patella. Once you find that joint, just go another 1 to 2 inches distal. That way you make sure to catch the knee joint. Okay, so let's try it out. Gonna take our patient. All right. So we'll have the leg turn AP. Okay, so can you turn this foot, put your toes at the ceiling? Good. And now we're gonna take this foot and just turn very slightly internally, right? Not going all the way, right? Just very, very slightly. So that if you check those condyles here, right, those condyles feel nice and flat. Okay, over here, patella, apex, half an inch. So that's gonna be my knee joint. And so the bottom of my light is gonna be about 1 inch or 2 below this. Oops, a little bit too far. Okay. So, does that make sense? Right. Let's turn this a little bit. Good. Make sure that we're in the middle of the leg. Pat down the clothes if you have to. Follow me. Follow me to the soft tissue borders, right? So you still want the soft tissue on both sides of the leg, right? You don't want to collimate only to the bone. You want to be able to see the muscle and stuff surrounding it as well. Which leg is this? Right leg, very good. So, right marker. And that's it. Oh, actually, no, I'm sorry. All right, that's it. That is our AP femur, distal.
How far did you go down on the knee again?
About 1 to 2 inches past the knee joint.
Okay.
And that's for
For the
the
one?
border, like the bottom.
That's
and
right.
That doesn't really necessarily have like a specific.
This part?
Yeah.
No.
Okay.
So you do not need to worry about where the center of this crosshair is.
Okay.
Main thing is in the center of the leg this way, right? And just far enough past the knee joint that you catch the joint space.
Is it always 1 to 2 inches, or does it depend on like how tall the patient is?
Always 1 to 2 inches. And you'll see that a lot for long bones. Anything where you have a joint, you usually go 1 to 2 inches past the joint. All right. So far, so good. All right. AP proximal femur now. Now we're going to come up higher. For this, shielding is going to be much tougher because you're going to be all the way up here. You can't really shield that section since this is the anatomy we care about. So once again, sorry Emily, turn your foot. Very good. Right there. This time we're going to stay here in the middle of the leg, but now we're going to put the top of our light above the hip joint. How far do we go above the hip joint? You feel here, and you look for the as is. The as is above the hip, so you put the top of the light at the as is. You catch the as is, you know you have the hip joint. Does that make sense? Do this. All right, I'm at my as is. I'm in the middle of my leg still. Just open up a little bit more to catch my soft tissue. Now, there is one more change you need to remember to make here. The amount we turn the leg will change between proximal and distal. distal, it was just a very, very slight turn, right, to get the knee AP. Because we're up here at the hip, we now need to turn the foot enough to make the hip look AP. To get an AP hip, we need to turn the foot about 15 degrees internally. So you need to turn the leg 15 degrees internally. What other projection have we talked about?
Mortise.
That's right, the mortise. The mortise is also a 15-degree internal rotation, right? So as long as you can make the ankle look like a mortise, you know you have the proper rotation. Does that make sense? So a lot like what you've already done before. Just get a nice mortise down here, and this should be perfect. Now, some more warnings. When you do rotate the foot, make sure that you're actually rotating the entire leg, right? For that 15 degrees. Don't just come here, take the foot and do this, right? Don't just twist it like that. Because yeah, the foot's moving, but the leg isn't. So nothing's gonna happen up here at the hip joint, right? The whole leg needs to go internal. And secondly, when you try and turn the leg internal, do not grab the bottom of the shoe. Right? Do not grab the shoe to turn the leg internally. Because after you do that, what are you going to do? You're going to come up here, you're going to palpate, you're going to do stuff, you're going to touch the machine. As the patient gets off, you're going to grab their hand to help them up, you're going to shake their hand, and you're going to spread whatever's on the bottom of that shoe everywhere. So do not touch the bottom of that shoe. Right? So you notice that when I'm trying to rotate the foot, how do I do it? I'm grabbing here at the ankle, I'm grabbing here at the knee, right? I'm grabbing the actual leg to rotate. All right, so a little bit more, good. Or nice 15-degree internal rotation. Mortise of the ankle down there gives us a nice AP of the hip up here. Okay, marker, once again, is down here. For the femur, I recommend putting the marker towards the bottom corner because the leg starts thick at the top, gets thinner at the bottom, gives you this nice triangle to squeeze your marker into. Right? If you marked up here, you'll need to open your collimation to catch it. Better to put your marker down here, and then you can collimate more. Make sense?
Yes. So that's like the top part of the light is at the as is. That's whenever we were doing the abdomen, that's what everybody kept palpating, right?
Correct.
Okay.
You just go to the front of the patient, right? For me, I just like put my hand right here and like, oh, bony thing as is, because it's the anterior iliac spine, right? Good. So, any questions about AP femur? We did 2 pictures so far. You can relax your leg. Now we need to do lateral femur. To do our lateral femur, this is going to be kind of similar to our lateral knee. So, Emily, what I'm going to have you do is I'm going to have you scoot just a tiny bit more to your left first. Good, and now turn your whole body to face me. All right, very good. Stay like that. Okay. So, we turn our patient into a lateral position. Now, there are 2 ways you can proceed from here. Just like with the knee, the unaffected leg can either come in the front or it can stay in the back. It is your choice which one you do, right? Whatever you're more comfortable with, whatever your patient is more comfortable with. What I'm going to be showing you today is it with the leg behind, right? But if you want to bring the leg in front, that's fine. Just make sure you minimize your superimposition when the legs cross over each other. Right. So, Emily, what I'm going to have you do is you're going to slide this left leg back a bit and move the knee out of the way. Great. Stay just like that. All right, and so let's take a look at this distal femur again. All right. Can you just push your hips forward a little bit more? Good. I'm just gonna slide your leg back a bit. Alright. So for this one, our leg is gonna have a bend to it. The book recommends about a 45-degree angle. Doesn't have to be too exact, just make sure that you have a nice bend. Okay. I'm gonna have you turn your hip toward me a little bit more. Yep, turn your hips toward, no, don't slide, but turn your hip. Bring this left hip, there you go. Good, right? Because we're trying to get this into a nice lateral position. All right. So, centering is the same as before. We're gonna come down midway, come down to midline of the leg, and we're gonna center past the knee joint. How do you find the knee joint on a lateral?
The crease?
Close.
That's the
Well,
intermediate.
Oh, the epicondyle?
That's right.
I
so
mean
you-
the condyle?
That's right. You find the condyle, you go an inch down, there's your joint space. So we're just gonna go a bit past this joint right here. Okay, just a little bit past the joint, 1 to 2 inches. All right. If you take a look over here, right, I have light in the back still, right, and only all the way up at the top do I have shadow, right from this leg covering it. Right. So, see how I'm still focused primarily on the right leg here, right? I can even column it a little bit, just so that I don't see the superimposition here. Right. Check to make sure this is lateral by checking my condyles. Okay, yep, looks pretty lateral to me. And so this is our lateral distal femur. Does that make sense?
Mhm.
Right. Position it very similar to a lateral knee, just no angulation on your tube, right? No tube angle.
Do you have this twisted or is it straight? Because I just thought it would be no
So,
straight.
right now it's straight.
Okay.
So the reason why I was able to leave this straight was because I got the femur pretty much going straight down the table, right? That's when I asked her to slide her hips forward,
Right.
and I pushed the knee back, right? That got the leg nice and straight.
Right, okay.
So sometimes, yes, you will see this. I'm gonna just slide your knee down. Right. So right leg comes off at an angle.
Mhm.
If this happens, then yes, you may need to angle your tube as well. But ideally, if you want like a really, really nice picture, rather than the leg coming off at an angle, you can just slide this back to get it more straight.
Right, okay.
Okay. From here, we are gonna do proximal femur, the upper part. Where do we center? Exactly the same as before. We are gonna put this top of the light at the level of the as is. Let's just move that out of the way. Let's see if we can find our as is this time. Okay, there we go. So top of the light, up here at the as is. Just enough to give me room for my marker. Okay. And this is our lateral proximal femur. Once again, just notice that the hip here, it's turned lateral, but not all the way lateral, right? We pull it back just enough so that we don't superimpose this leg on top of this leg. Right? Unaffected leg should not cover up the affected leg. So, any questions here?
Are we ever gonna do, are femurs ever done weight bearing?
No. No, I've never seen any weight-bearing femurs. Because remember, the femur is the weight-bearing bone of the body, right? So, if there's something wrong with the femur, it's usually a fracture. If it's a fracture, you definitely don't want to put weight onto, you don't want the patient to try and put weight onto the femur because now that weight-bearing bone is no longer intact. So, no, you're probably not going to see weight-bearing of the femur. Knees, yes, you'll see that because of the joint space. Foot, yes, you may see that because of something like a strength injury. but not for the femur. But good question. No, wrong one. All right. So that takes care of the femur.